Hi, my name's Andrew Cullen. I'm with the Los Angeles Police Department. I'm a lieutenant of police there, and I'm in cohort 2301, 2302. In 1987, Joseph Robinson was in a mental health crisis when his family called the police to ask for help. He was armed with a knife and he was committing self-mutilation. Police responded and he charged at the police, where an officer-involved shooting occurred and he was killed. As a result of this shooting, the Memphis Police Department sought to change how police respond to persons with mental illness and crisis. And from that came crisis intervention training. By 2004, Congress had appropriated funds to have crisis intervention training go out nationwide to departments all over the country. And within 20 years, it was the dominant response strategy to persons with mental illness and crisis. This training set out to do three things: assist officers in identifying persons with mental illness, increase referral rates as opposed to arrest, and reduce injuries or harm, sometimes referred to as uses of force. The first two, crisis intervention training is very successful at, but the last one, my research found, was not successful. While crisis intervention training offers many positive things, a reduction in uses of force is not one of them. And given that this is the dominant response strategy for persons in crisis, we need to figure out a way that we can reduce uses of force with persons with mental illness. Next in my thesis, I looked at other similar parallel problem spaces, and I found seclusion and restraint reduction. In 1998, the Hartford Courant published an article called Deadly Restraint, which was a 5-part series exploring positional asphyxiation deaths that occurred within psychiatric care facilities. Shortly after the publication of this article, Congress instructed the Government Accountability Office to conduct an investigation and found that 24 people had died as a result of positional asphyxiation from seclusion or restraint use. Shortly after the GAO's article, Medicare changed their rules following the GAO's recommendations that there should be guidelines when seclusion and restraint can be used and reporting responsibility if it is used and a death occurred or there are injuries. In 2000, Congress passed the Children's Health Act and mandated this by law. Immediately, the psychiatric care industry came together and started trying to find ways to successfully reduce seclusion and restraint use. They started publishing newsletters, conferences, and worked collaboratively amongst many different facilities to identify successful means of reducing seclusion and restraint use. Years later, they were able to publish best practices called the 6 core strategies. And within 10 years of the law being passed, seclusion and restraint use in psychiatric care facilities had fallen precipitously, 95% in some cases. This was a huge success. But why was that so successful in reducing deaths in psychiatric care facilities, and yet crisis intervention training is not successful in reducing uses of force? I started doing a comparative analysis between these two systems. Now, I acknowledge there is a difference between a police officer responding to someone in the field with an unknown mental health diagnosis, unknown medication history, and an unknown if they're armed or not, versus somebody within a psychiatric care facility whose medication status is known and diagnosis is known. These two problem spaces, while similar, are not parallel. But seclusion and restraint went about identifying successful means to reduce seclusion and restraint and was very successful. And crisis intervention training, on the other hand, had many goals and were successful in some, but not in others. This is what was very interesting. Crisis intervention training set out to have many goals: identification, referral, and reduction in force. Whereas seclusion and restraint reduction had one goal: reduce seclusion and restraint use. This single focus significantly assisted seclusion and restraint reduction success because they had one goal in mind. Next, I found that seclusion and restraint had a reporting mandate. They were required to track seclusion and restraint use, reporting it to the federal government, and if they failed to comply, would not receive federal funding from Medicare. This reporting requirement created a really robust data set that academic institutions were able to analyze and start identifying successful practices that were reducing seclusion and restraint use or not reducing seclusion and restraint use. In fact, the mere act of forcing reporting on seclusion and restraint use actually began to lead to a modest reduction in seclusion and restraint use. Crisis intervention training, on the other hand, does not have a reporting requirement. In fact, not all police departments even respond currently to the FBI's use of force database. And if they do, there's no requirement to delineate whether or not force is used against a person with mental illness or somebody who's intoxicated. There is no reporting requirement. As a result of that, what this means is we don't actually have a data set that we can analyze to see if an intervention strategy is successfully reducing use of force in police departments. These differences between the two systems are significant. Seclusion and restraint in 10 years was able to lead to a dramatic reduction in seclusion and restraint use, whereas police have now been doing crisis intervention training widespread for almost 20 years, but we have no data to show that it is reducing uses of force with persons with mental illness. Police can make small changes in their current processes that can lead to significant chances of us being able to identify a successful strategy for reducing uses of force with persons with mental illness. First, we can report on use of force usage with persons with mental illness or intoxicated individuals, and we can put that into the use of force database by the FBI. Next, we can start conducting analysis because we will now have a control period before and after any interventions, so that we can start identifying if an intervention we're employing is successfully reducing uses of force, and if it's not, how we can change it. Finally, this allows us to start doing comparative analysis between municipalities that are of similar sizes, so that large cities and small cities can find other communities that have similar populations and demographics and can identify strategies that may or may not be working in those communities. Finally, the Department of Justice can really start forcing the reporting of use of force information. Like Medicare required the reporting of seclusion and restraint use in order to receive funding, the Department of Justice can do something very similar with Department of Justice law enforcement grants, that in order to receive them, you have to participate in the FBI use of force database, and you have to track uses of force usage with persons with mental illness. By doing this, we can create a data set that academics are able to start identifying successful practices. If we make these changes to our processes, we can lead to a reduction in uses of force with persons with mental illness. Unlike seclusion and restraint reduction, it should not require Congress to mandate this. Law enforcement should be guided by the principle of reverence for human life, that our encounters with persons with mental illness and crisis is an encounter with someone who needs medical help, and we should treat it as such. This is not a situation where we're apprehending a suspect suspected of a criminal activity and we're guided by Graham versus Connor. But on the other hand, we are encountering somebody who needs medical assistance. And that should slow us down and change our policies on apprehension of persons who need to be taken to a hospital for medical care. Police should not need Congress to tell us to do this. We should do this because it is the right thing to do and believe that it is possible to reduce our uses of force with persons with mental illness.